Open Stax Psychology Chapter 10 Continued Hunger and Eating. Eating is essential for survival. It is no surprise that a drive like hunger exists to ensure that we seek out sustenance. While this chapter will focus primarily on the psychological mechanism that regulate hunger and eating, powerful social, cultural, and economic influences also play important roles. This section will explain the regulation of hunger, eating, and body weights, and we will discuss the adverse consequences of disordered eating. Psychological mechanisms. There are a number of psychological mechanisms that serve as the basis for hunger. When our stomachs are empty, they contract. Typically, a person then experiences hunger pains. Chemical messages travel to the brain and serve as a signal to initiate feeding behavior. When our blood glucose levels drop, the pancreas and liver generate a number of chemical signals that induce hunger, and thus initiate feeding behavior. For most people, once they have eaten, they feel satiation, or fullness and satisfaction, and their eating behavior stops. Like the initiation of eating, satiation is also regulated by several psychological mechanisms, such as blood glucose level increase. The pancreas and livers send signals to shut off hunger and eating. The food's passage through the gastrointestinal tract also provide important satiety signals to the brain, and fat cells release leptin, a satiety hormone. The various hunger and satiety signals that are involved in the regulation of eating are integrated in the brain. Research suggests that several areas of the hypothalamus and hindbrain are especially important sites where the integration occurs. Ultimately, activity in the brain determines whether or not we engage in feeding behaviors. Metabolism and body weight. Our body weight is affected by a number of factors, including gene-environment interactions and the number of calories we consume versus the number of calories we burn in daily activities. If our calorie intake exceeds our caloric use, our bodies stores excess energy in the form of fat. If we consume fewer calories than we burn off, then stored fat will be converted to energy. Our energy expenditure is obviously affected by our levels of activity, but our body's metabolic rate also comes into play. A person's metabolic rate is the amount of energy that is expended in a given period of time, and there is a tremendous individual variability in our metabolic rates. People with high rates of metabolism are able to burn off calories more easily than those with lower rates of metabolism. We all experience fluctuation in our weight from time to time, but generally, most people's weights fluctuate within a narrow margin in the absence of extreme changes in diet and or physical activity. This observation led some to propose a set point theory of body weight regulation. The set point theory asserts that each individual has an ideal body weight, or set point, which is resistant to change. This set point is genetically predetermined, and efforts to move our weight significantly from the set point are resisted by compensatory changes in energy intake and or expenditure. Some of the predictions generated from this particular theory have not received empirical support. For example, there are no changes in metabolic rate between individuals who had recently lost significant amounts of weight and a control group. In addition, the set point theory fails to account for the influence of social and environmental factors in the regulation of body weight. Despite these limitations, set point theory is still often used as a simple, intuitive explanation of how body weight is regulated. Obesity. When someone weighs more than what is generally accepted as healthy for a given weight, they are considered overweight or obese. According to the Center for Disease Control and Prevention, an adult with a body mass index between 25 and 29.9 is considered overweight. An adult with a BMI of 30 or higher is considered obese. People who are so overweight that they are at risk for death are classified as morbidly obese. Morbid obesity is defined as having a BMI over 40. Note that although BMI has been used as a healthy weight indicator by the World Health Organization, the CDC, and other groups, its value as an assessment tool has been questioned. The BMI is most useful for studying populations, which is the work of these organizations. It is less useful in assessing an individual since height and weight measurements fail to account for important factors like fitness level. An athlete, for example, may have a high BMI because the tool doesn't body's percentage of fat and muscle in a person's weight. Being extremely overweight or obese is a risk factor for several negative health consequences. These include, but are not limited to, an increased risk for cardiovascular disease, stroke, type 2 diabetes, liver disease, sleep apnea, colon cancer, breast cancer, infertility, and arthritis. Given that it is estimated that in the U.S. around one-third of the adult population is obese, and that nearly 2/3 of adults and 1 in 6 children qualify as overweight. There is substantial interest in trying to understand how to combat this important public health concern. What causes someone to be overweight or obese? You have already read that both genes and environment are important factors for determining body weight, and if more calories are consumed than expended, excess energy is stored as fat. However, socioeconomic status and the physical environment must also be considered as contributing factors. For example, an individual who lives in an impoverished neighborhood that is overrun with crime may never feel comfortable walking or biking to work or to the local market. This might limit the amount of physical activity in which he engages and result in an increased body weight. Similarly, some people may not be able to afford healthy food options from their market, or these options may be unavailable. Therefore, some people rely primarily on available, inexpensive, high-fat, and high-calorie fast foods as their primary source of nutrition. Generally, overweight and obese individuals are encouraged to try to reduce their weight through a combination of both diet and exercise. While some people are very successful with these approaches, many struggle to lose excess weight. In cases in which a person has had no success with repeated attempts to reduce weight or is at risk for death because of obesity, bariatric surgery may be recommended. Bariatric surgery is a type of surgery specifically aimed at weight reduction and involves modifying the gastrointestinal system to reduce the amount of food that can be eaten or limiting how much of the digested food can be absorbed. A recent meta-analysis suggests that bariatric surgery is more effective than non-surgical treatments for obesity in the 2 years immediately following the procedure. Due to date, no long-term studies yet exist. Eating disorders. While nearly 2 out of 3 U.S. adults struggle with issues related to being overweight, a small but significant portion of the population has eating disorders that typically result in being normal weight or underweight. Often, these individuals are fearful of gaining weight. Individuals who suffer from bulimia nervosa and anorexia nervosa face many adverse health consequences. People suffering from bulimia nervosa engage in binge eating behavior that is followed by an attempt to compensate for the large amounts of food consumed. Purging the food by inducing vomiting or through the use of laxatives are two common compensatory behaviors. Some affected individuals engage in excessive amounts of exercise to compensate for their binges. Bulimia is associated with many adverse health consequences that can include kidney failure, heart failure, and tooth decay. In addition, these individuals often suffer from anxiety and depression, and they are at an increased risk for substance abuse. The lifetime prevalence rate for bulimia nervosa is estimated at around 1% for women and less than 0.5% for men. As the 2013 release of the Diagnostics and Statistical Manual, 5th edition, binge eating disorder is a disorder recognized by the American Psychiatric Association. Unlike with bulimia, eating binges are not followed by inappropriate behaviors, such as purging, but they are followed by distress, including feelings of guilt and embarrassment. The resulting psychological distress distinguishes binge eating from disorders from overeating. Anorexia nervosa is an eating disorder characterized by the maintenance of a body weight well below average through starvation and/or excessive exercise. Individuals suffering from anorexia nervosa often have a distorted body image, referenced in a literature as a type of body dysmorphia, meaning that they view themselves as overweight even though they are not. Like bulimia nervosa, anorexia nervosa is associated with a number of significant negative health outcomes: bone loss, heart failure, kidney failure, amenorrhea, cessation of menstrual period, reducing function of the gonads, and in the extreme cases, death. Furthermore, there is an increased risk for a number of psychological problems, which include anxiety disorder, mood disorder, and substance abuse. Estimates of the prevalence of anorexia nervosa vary from study to study, but generally range from just under 1% to just over 4% in women. Generally, prevalence rates are considerably lower for men. While both anorexia and bulimia nervosa occur in men and women of many different cultures, Caucasian females from Western societies tend to be the most at-risk population. Recent research indicates that females between the ages of 15 and 16 are most at risk, and it has long been suspected that these eating disorders are culturally bound phenomena that are related to messages of a thin ideal often portrayed in popular media and the fashion world. While social factors play an important role in the development of eating disorders, there is also evidence that genetic factors may predispose people to these disorders.